Hi friends, welcome to my blog. Today I will be discussing about the scrub typhus. As we know, scrub typhus is an important cause of fever, and it also comes under the differentials of pyroxia of unknown origin. Most of the time, being a physician, we don't consider it in the differentials of the fever, and if it is left undetected, or if we miss its findings, and the patient can end up with multiple complication, even death also. Friends, scrub typhus is caused by an arthropod vector. uh, the arthropod vector belongs to the family of Trombiculidae, and this vector is Orantia susu and the human beings acquire this typhus when the mite feed on human beings, and this mite is called shigar. This mite which feeds on human being is called shigar. Very characteristic lesion of the scrub typhus is scar formation. A scar is basically a lesion that starts as a vesicular lesion which at the site of mite feeding, and it later ulcerates, and it forms a black necrotic center and erythematous border with regional lymphadenopathy. The patient presents with fever, muscle pain, cough, GI symptoms like diarrhea, GI bleeding, liver and spleen enlargements, and if the patient is left untreated, then he may end up with various CNS complications like meningitis, acute respiratory distress syndrome, and renal involvement, kidney involvement, and if it involves the cardiovascular system, the patient can have myocarditis, etc. Mortality in scrub typhus is usually less than 1% to 50%. Scrub typhus basically got its name from scrub. It is a type of vegetation, that is a terrain between woods and clearings, that harbors this vector. And typhus means fever with stupor, or at times we call it fever with smoke. And susuga means small and dangerous, and mushi means mite or insect. In India, scrub typhus was initially usually seen in Shivalik range from Kashmir to Assam, Satpura range, Himachal Pradesh has also seen, Himachal Pradesh, Sikkim, they have also seen various outbreaks of the scrub typhus, but now the scrub typhus is also being seen in urbanized cities like Delhi also. The rodents are important host, but these rodents, they don't succumb to the disease. Human being usually got it when they are exposed to the mites of this scrub while walking, sitting, or lying on the infested ground. The incubation period is usually 10 to 12 days, and it is an important part of pyroxia of unknown origin. The first sign is usually the vesicular lesion at the site of mite feeding, which is usually initially a vesicular lesion which later ulcerates, form a central necrotic area with borders of erythematous borders, and at the end of first week The maculopapular eruptions, they appear. They usually start from the trunk and they spread over the limbs, and systemic symptoms usually are seen in second week, and they may involve CNS, like patient can present with altered sensorium, meningitis and signs of meningism, respiratory involvement in the form of acute respiratory distress or pneumonia, GI symptoms including GI bleed. Patient can also have deafness, dysarthria, dysphagia, but though they are rare. When should we suspect the patient with fever as a case of typhus? The patient will be febrile. He may have icterus or may not have. Patient is usually not pale. He will have bilateral conjunctival injections, means his eyes or conjunctiva will be suffused, means they will be red. He will have normal pulse and BP. We will find ulcer usually in the groin region, which may have a central blackened crust with erythematous hollow. This is called eschar. I will in next slide I will show what are the most important sites for scar formation, and the patient may have enlarged lymph nodes involving the sites. The patient will have maculopapular eruptions, which are usually seen in the first week. Initially they involve the trunk and they later spread to the limbs, and scars are usually seen in the groin. These erythematous maculopapular rashes, as we know, they initially involve trunk, later they involve upper and lower limbs, but they usually spare the face and scalp. Abdomen will have mild splenomegaly of less than 3 centimeter. A patient may have mild hepatomegaly also, but usually abdomen is non-tender. Patient will have a respiratory rate of, if he is in respiratory distress, the respiratory rate may be more than 20 per minute. Because of such patient, they may have bilateral pleural effusion, also bilateral infiltration in both lung fields. They can have crepitations also. If the musculoskeletal system is involved, then it will definitely, the patient will have marked muscle tenderness, and such patient at times, though their CNS examination will be normal, but at times they may have signs of meningitis, or they may be in altered sensorium. Whenever such patient presents with all above symptoms, with typical presentation sign and symptoms as I have mentioned, we must suspect that patient is having scrub typhus. We should consider it in a differential diagnosis of the scrub typhus. These are the important sites where we find scars. If we see in the front, the head and neck regions, they have 19% chances of. Chest and abdomen 11.9%, and these are the groins, very common, it is 33%. Patient can have a scar in the axilla, and that is about 21%. Similarly, back of the our genitalia, inguinal region, buttocks, they all constitute majority of the sites for scar formation. So whenever the patient of the fever comes to us with the sign and symptom which I mentioned in previous slides, we must thoroughly examine such patient for any scar formation, and if we very generously or thoroughly inspect the patient's body, we will definitely find scars in the at the sites which are mentioned, and usually they are found in the groins, genitalia, and though they can be seen at any site, well, but we should not miss the scar. Presumptive diagnosis of typhus should be made when the patient with both exposed to sugars stayed or went into risk area within 2 weeks before the onset of the symptoms, or reported acute fever within 2 weeks of the onset of the symptoms. Reported acute fever within 2 weeks of the onset of the symptoms and exposed to sugar. The patient may be having accompanied with at least one of these symptoms: headache, myalgia, profuse sweating, cough, conjunctival injection, lymphadenopathy, maculopapular rashes, and patient may also have accompanied with at least one presence of scar. As if the scar is present, the most likely we must be sure that patient is having typhus. The patient will have positive immunochromatographic test for scrub typhus also. Diagnosis of scrub typhus can be made if the patient is having history of fever with scar on the sites which I mentioned in the previous slide. It is a clinical diagnosis and we must not miss it. It is a clinical diagnosis. In serology, scrub typhus serology, we should do his IgM, IgG. IgM is usually positive at the end of first week and IgG positive at the end of 7 week. If they are positive, then we must also think that patient is having scrub typhus and we should treat them accordingly. Wheel Felic test is basically very cheap test in its effect. It has a high specificity but low sensitivity. A titer of more than 1:320 or fourfold rise in the titer starting from 1:50 is usually diagnostic of scrub typhus. However, the indirect immunofluorescence antibody test, it is a gold standard test. It is the gold standard test for the scrub typhus. This indirect immunofluorescence antibody test basically detects the presence of typhus specific antibody bound to smear of scrub typhus antigen, and this can confirm the infection before the seroconversion. Moreover, other tests like cell culture is also available, but it usually takes about 4 weeks time. PCR, polymerase chain reaction from skin biopsy, lymph node biopsy, they can also add to diagnosis. The patient with scrub typhus will have the blood picture of this leukocytosis, thrombocytopenia, increased SGOT-PT levels. Such the hypoalbuminemia and hyperbilirubinemia, they are not very uncommon. They can be seen. Patient can have increased creatinine level if the renal involvement is there. Hepatosplenomegaly, patient can have bilateral pleural effusion, bilateral infiltrate, as such patient will end up with acute respiratory distress syndrome. And so these are the findings which we will see in lab or other tests available for this. Let's come to the treatment part of the scrub typhus. Since we know doxycycline is very effective, chloramphenicol is effective. Doxycycline 200 milligram given day 1 followed by 100 milligram every 12 hourly can be given for 7 to 10 days, 7 to 12 days, 14 days. I will once again repeat the treatment. Tetracycline and chloramphenicol, they are basically mainstay of therapy in patient with scrub typhus. The recommended treatment regime for scrub typhus is doxycycline 2.2 milligram per kg body weight, 2.2 milligram per kg per dose, BD पर orally या फिर IV, maximum 200 milligram per day, maximum 200 milligram per day for 7 to 15 days. So dose of doxycycline is 2.2 milligram per kg per dose BD per orally or IV, and maximum 200 milligram per day for 7 to 15 days. Okay, we can give tetracycline. The dose of tetracycline will be 25 to 50 milligram per kg per day divided every 6 hourly, ठीक है, पर ओरली फॉर 7 to 15 days. मैक्सिमम इसका भी 2 ग्राम. Prophylactically, if the patient is going to that area, we can give 200 milligram as a single dose. The alternative regime, which include chloramphenicol, though it is a 500 milligram every 6 hourly, 7 to 15 days, the dose will be 50 to 100 milligram per kg per day, 6 hourly IV. Maximum we have to give 3 gram per 24 hour, 3 gram per 24 hour, or we can say 500 milligram QID orally for 7 to 15 days. This is the recommended dose of chloramphenicol. If we use chloramphenicol, its serum concentration should be monitored, and it should be 10 to 30 microgram per ml, and therapy should be continued for minimum of 5 days until the patient has been afebrile for at least 3 to 4 days to avoid the relapse. It is the chloramphenicol should be avoided during pregnancy, and its reduced doses should be, it is contraindicated in pregnancy, and we have to decrease the dose during the in the patients with hepatic impairment. The other antibiotics which can be given, they are azithromycin, rifampicin, roxithromycin. They are effective either as a doxycycline or for short exposure. Chemoprophylaxis with doxycycline 200 milligram weekly can prevent the disease, but it permits the infection. And so the prophylaxis for scrub typhus with doxycycline has shown promising result when started before exposure to the infection. Similarly, in children with scrub typhus, the dose are mentioned as 5 milligram per kg per day of doxycycline for 7 days, and similarly chloramphenicol 50 milligram per kg per day in divided doses every 6 hourly. Friends, we can give azithromycin in the pregnant ladies if they suffer scrub typhus. This picture we see that this is the scar formation. It has erythematous borders and central necrotic area. If the patient presents with fever for last 1 week or 2 weeks, and we are not able to clinch the diagnosis, we must undress him and look the important areas which I earlier mentioned for scar formation, as these are very prominent in groins, axillas, back, buttocks. I hope I am able to make you understand the clinical aspects of scrub typhus, its presentation, diagnosis and management part. I will prefer that you people read Harrison book of internal medicine, the updated versions of medicine update by Indian Association of Physician, IAP updates for updating your medical skills. If any query, please let me know. You can drop a message uh, or suggest me if you have any suggestions, and your suggestion will encourage me to come up with more enthusiasm to make you understand medicine better, and it will definitely will encourage me to update my knowledge also. Thank you very much.